So, hello. Thank you very much for everyone joining. Welcome to the penultimate, webinar of the Medicolegal teaching series. For those of you who don't know, my name is Alvin. I'm currently a doctor working at the North Middlesex Hospital, but also the lead for Medicolegal at Mind the Bleep. And so I've been running this with Devesh and Aditi for the last couple of months. So thank you for attending today. We will be doing a lecture on safeguarding. Just before we start, I just want to lay some ground rules. So in terms of actually sort of posting comments, wanting to ask any questions, this functions as a YouTube live. So any comments will just post into the YouTube comment section and I will see. I've got it up on my laptop as well as on my phone. So when there's a nice break, I will endeavor to answer those promptly. As well as at the end of the lecture, I will be posting a feedback form. So please feel free to scan that. In that way, you'll be able to get your certificate as well to show that you've attended the lecture, and you'll be able to provide any feedback for us that we look at and we incorporate into the rest of our lectures. Good. So a few people have joined so far. Okay, so I'm going to go ahead with this now. So in the comments, if you guys can, so I'm going to share my screen. Please let me know if you can actually, let's see, entire screen. So please let me know if you can actually see this or not. Just want to check. Is that all good? If anyone could post in the comments, that'd be very useful. Okay, so I'm assuming that's okay. So I'll turn my camera off and we shall start with the presentation. So just going full screen now. Hope everyone can see it. Let's see, I think I can minimize that as well. Okay, so so my name is Alvin. Thank you very much for attending the penultimate Medicolegal teaching series. Today's lecture will be on safeguarding. My name is Alvin, doctor at North Middlesex, have a background in a master's in healthcare ethics and law, and thus started this teaching series. So today we'll predominantly be talking about adult safeguarding. I'm sure many of you will have come across it in your clinical practice, and we'll be touching on children and young adults as well, but that won't be the main focus of today. So, as with the rest of all of these lectures, we need to make a legal disclaimer. So, any information included in this webinar is for purely educational purposes. The information included in this webinar is up to date to the best of mine and our knowledge. And as always, should you require further independent legal advice, please seek a professional legal opinion. So please don't base any of these lectures if you are going through true legal process. So the learning objectives today. So identify key UK safeguarding legislation, to understand the principles of safeguarding, and to understand the statutory guidance and apply this to clinical scenarios. So we're going through a couple of case studies later, so you can apply that knowledge and assess individuals at risk and subsequently refer this on appropriately. So I think it's important to discuss the current landscape with regards to adult safeguarding and look at the figures. So the data from the Safeguarding Adults collection, as collected by the Department of Health, identifies that in the year between 2023 to 2024, there were 600,000, just over 600,000 concerns of abuse reported. And when comparing that to the previous year, 2022 to 2023, that was an increase of 5%. Now, this is a marginally lower increase compared to the year prior to that. So it was 9% the year prior to that. However, it does represent a growing concern and a very important aspect of our clinical practice for all healthcare staff, not only doctors. Importantly, almost 177,000 Section 42 inquiries were made under the Care Act 2014. So specifically, the Care Act 2014, Section 42 requires that local authorities must make inquiries or get relevant personnel to do so if they believe that an adult is experiencing or is at risk of abuse, neglect, and all other types of, any sort of concerning abuse. Thus, an inquiry should establish whether an action needs to be taken to prevent or remove that aspect of risk. And I think quite a comforting number is that 91% of those concluded Section 42s resulted in a removal of some form of risk. Is good to know. Good to know. And of those, neglects and acts of omission was the most common form of abuse reported at 34%. And importantly, 46% of those occurred within the individual's own home, thus highlighting the need for sort of robust frameworks to identify those at risk in their own home. And so GPs, those involved in primary care, are thus best suited. Similarly, we'll touch upon the landscape for children as well. So currently, almost 400,000 children are identified as in need of support and protection. So these children are classified as children in need. This is a legal definition under the Children's Act of 1989. And they include a whole plethora of categories, including those on child in need plans, on child protection plans, those that are looked after under a local authority, care leavers, and disabled children. The list is exhaustive. This also includes those who are over the age of 18 who still continue to receive this support as well, whether it be care, accommodation, or various other forms of support. And importantly, almost 600,000 referrals were made to the Children's Services in the year 2023 to 2024. So when looking at both the adult and children's landscape, it does highlight the importance of safeguarding children and adults within our societies. So there are quite a lot of statutes or legislation that underpin safeguarding practice within the UK. Now, the list is rather exhaustive, and I'm not going to go into detail with all of it. However, these all in combination give the legal basis for crimes that can be committed in relation to safeguarding give the legal basis for types of abuse, as well as how to determine capacity. And these statutes are embedded in both international and domestic legislation. Thus, this creates a legal and professional responsibility on all clinicians to incorporate appropriate safeguarding practice that's in line with the, well, most up-to-date legislation. So if there's going to be one thing or one statute that you remember from today's webinar, it is the Care Act of 2014 that provides the legal basis for safeguarding and the principles for which we should be following as clinicians. Importantly, the Care Act 2014 is specific to England. In Wales, we have the Social Services and Wellbeing Act of 2014 that imposes a duty on local health boards and NHS institutions to inform local authorities if they have any concerns regarding adults at risk. Similarly, the Adult Support and Protection Act 2007 is what is utilised in Scotland. And they similarly have a code of practice and guidance that goes along with the legislation. And lastly, the Adult Safeguarding Prevention and Protection and Partnership sets out the policy in Northern Ireland. Now, whilst there are slight nuances between each bit of legislation, it's important to note that the principles are wholly the same. And as clinicians, fair enough, the referring bodies might be slightly different, but the ways in which we should be acting and the responsibilities are wholly the same. So the Care and Support Statutory Guidance, Section 14 on safeguarding, that is the guidance that goes along with the Care Act 2014. It's a rather lengthy document, around 500 pages. So I mean, for those of you who are interested, I'd very much recommend reading it, as it sets out in detail everything that we need to know. However, the adult safeguarding roles and competencies for healthcare staff and guidance, that is a more concise bit of guidance that we can read through, and it's made to be bite-sized and easily digestible for clinicians. So, importantly, what is adult safeguarding? So it's a rather complex area of practice, and there's no sort of, each scenario is very different. So one group of adults who may require groups of adults who require safeguarding is diverse and ranging from individuals who are unable to manage any aspect of their daily activities to those who might be experiencing a short-term illness or something, a temporary disability. Multiple services may be involved depending on the patient's needs, and thus makes it quite challenging for individuals as well as safeguarding leads to identify the most appropriate people to involve. I think, as in general, the important components about adult safeguarding is preventing harm and reducing risk. So early intervention, finding those that are at risk and then reducing that risk will subsequently prevent any further issues arising. So supporting autonomy, so making sure that we're going with a patient-centered approach, ensuring we think about the patient's best interest, as well as ensure that they're part of the decision-making process as well. obviously promoting positive outcomes, that is to say the least. And then it's very much focused, well, safeguarding as a whole concept is focused on personal well-being and how we can attain that. So the principles of adult safeguarding. There are 6 main principles, and this is all highlighted in the Care Act 2014. So starting with empowerment. So that is the personalization and of personalization of decisions for that individual and gaining the appropriate consent for that. So encouraging people to make their own decisions and feel comfortable with those. Prevention, as you can imagine, and as we've touched on earlier, is identifying those at risk and reducing those risks so that inappropriate consequences don't occur. Number 3 is proportionality. So this is a bit of a interesting one, but a proportionate response to any safeguarding concern must be taken, and it has to be the least intrusive response as well, and thus should reflect the risk that is being experienced by the individual. So protection, well, I guess ensuring that the appropriate individuals are monitoring the patient, they have the adequate support from local authorities, and ensuring doctors and nursing staff and all healthcare staff are aware of their situation. Now, partnership is kind of similar to empowerment. They go hand in hand. The fundamental relationship should be one of shared decision making. I'm sure you've heard of that to the death. It's quoted in a lot of GMC guidance, and is the appropriate way that we should be managing patient to doctor relationships. Yeah, and I guess coming back to the sort of importance of making it centered to the patient, with regards to partnership, working with local communities, working with local authorities, ensures that people get a control over their life. And lastly, accountability. So all these structures need to be accountable and transparent. Otherwise, we don't have the requisite bodies to identify issues that have occurred and then subsequently rectify those. So importantly, so the Care Act and the statutes that I showed earlier are the basis for all the types of abuse and all the types of abuse that essentially are criminal acts. So abuse and neglect, I mean, I've given a bunch of categories. However, they can manifest in various forms, and it's important to recognize this. So you have to be quite, quite flexible with your definition of abuse. So as well as clinicians, organizations and individuals should maintain a broad perspective on potential abuse, neglect and harm. And we should evaluate each of those situations, giving consideration to individual circumstances. And more often than not, it won't just be one type of abuse. So cast the net wide and consider what else could be occurring. So starting with physical abuse. So quite, I think, a rather more obvious type of abuse to identify. So things like pushing, restraining individuals, trying to look for those unexplained injuries, so bruising in the immobile patient, very much should be suspecting abuse at that point. So I did say we were going to focus on adults, but in children, the classic areas of the body that you shouldn't have any non-accidental injuries, those may be clues to an individual experiencing some kind of abuse. So sexual abuse, this is predominantly split into contact and non-contact. So contact would include things such as sexual assault, rape, exploitation, and anything that the individual may not have consented to. Whereas non-contact would include things like indecent exposure, abuse online, and exposure to pornographic content online. Psychological and emotional abuse. So this would include threats of harm, as well as abandonment, things like humiliation and verbal abuse from others around them. So whether it be online or those that are physically close to them. Financial abuse is often a slightly more difficult one to ascertain, but those who are coercing essentially the individual's financial arrangements, and this can take rather insidious forms, and as I'm sure some of you may have seen in clinical practice, can completely wipe out individuals. Modern slavery, as the name suggests, so trafficking, forced labor, what was I going to say? Neglect, yes. Next category is neglect. So this is the willful ignorance or omission of an individual's care needs, essentially. So whether that be medical, physical, or psychological, a deliberate attempt to not address these needs would be classed as neglect. Discrimination, so any discrimination based on race, gender, age, disability, religion. I think the list is actually rather lengthy. That would be a form of abuse. Getting into slightly more specific forms of abuse, so female genital mutilation. So that is any procedure that involves partial or total removal of the external female genitalia. And it's important for clinicians as there's a mandatory requirement to report this in individuals that are younger than 18 in the UK. And it is illegal as well to travel out of the UK for the purpose of performing female genital mutilation in those under 18. Interestingly, there isn't actually a mandatory requirement to report it for those who are adults. So next, yes, domestic abuse. So I've given this a slightly different category because it has its own specific definition under the Domestic Abuses Act 2021, in that so it includes all those forms of abuse above. However, the parties involved must be over the age of 16 and must be personally connected. So traditionally, you may think about married or civil partners. This also includes those who are about to become married or about to become civil partners as well as intimate partners who have a long established relationship, anyone who's shared parental relationship in relation to the same child, as well as in-laws as well. Importantly, this category includes things such as forced marriage, faith-based abuse, and coercive reproduction as well. And the slightly more niche areas, virginity testing and hymenoplasties. So these are criminal offences under the Health and Care Act of 2022. So if you notice any of these happening, it is very important as clinicians to be pursuing the appropriate safeguarding referral pathways. So, how are we doing for time? 20. Okay, fine. So, recognizing adults at risk is thus a very important consideration for clinicians. So, those that already have care and support needs. Adult safeguarding applies to those over 18 who have already established care and support needs, at risk of experiencing any of the forms of abuse that mentioned above, and subsequently aren't able to protect themselves due to their care needs. And whilst there's no blanket sort of guide on identifying risk groups, as a general rule of thumb, you can go with those who are frail, those that experience poor mental health, as well as those with physical, sensory, and learning disability. Unpaid carers, very important. You may have come across that in the hospital, in primary care as well. So families who have unwell individuals, and certain members of the family are made to be full-time carers without being paid, and often, actually no, I won't say often because I don't know the data, but sometimes will be coerced into the role, and those would be at-risk groups. Obviously, those who are homeless and those living with alcohol and drug abusers. These are very much some distinct risk groups. Okay, so let's go with a case study then, shall we? Okay, so hopefully you've retained a bit of what I've just spoken about. I know it's been a bit didactic. We'll move on to a more structured approach that you guys will find useful. I think trawling through all the legislation would be quite boring. So let's apply. So the case study. Mrs. Ahmed is a 75-year-old woman living with her adult son and his partner. She has mild dementia and mobility issues following a recent stroke. Her GP notices that Mrs. Ahmed has lost a significant amount of weight over the last 3 months and appears increasingly anxious during appointments, as well as looking very unkempt. She avoids eye contact and becomes visibly distressed when her son is mentioned. Subsequently, a home visit is arranged and the house is cold and poorly maintained. Her son is present, and when Mrs. Ahmed is questioned, he regularly interrupts and answers questions on her behalf. In a bid to understand her financial situation, you ask Mrs. Ahmed, but the son becomes aggressive and threatens to call the police. So, in relation to this, so what types of abuse can you recognize, firstly? And secondly, what factors of abuse can you recognize? What risk factors for abuse can you recognize? So I'm just going to pop back to the case study. I'll give you 30 seconds to have a quick think. Okay, feel free to post in the comments section. Okay, fine. So we will move on to, what types of abuse can you recognize? So there's obviously things like neglect involved. So with the significant weight loss, you start to think, has she been eating enough? Have her various care needs been appropriately addressed? As well as she's looking rather unkempt, suggesting that daily activities of living and daily care needs have not been met. And supposedly living with her adult son and partner, that does raise concerns about those two individuals that have been living with her. Now, with regards to whether Mrs. Ahmed is at risk, she very much is. She's well, I'm not sure if elderly is the correct word, but she's slightly older. She has cognitive issues and mobility, so physical disability as well. And all of these are contributing to her biological frailty, the stroke too. Oh, sorry, I just remembered the financial abuse as well. That's important to know, as he gets angry when that's mentioned. So yeah, these are the types of abuse in this case, as well as we've identified certain risk factors for this lady. So poor mental health, poor physical health, and overall greater biological frailty. Okay, so slightly moving away from it being more clinician focused. The Healthcare Act also highlights the responsibilities of NHS health providers and institutions, as well as separately, this is defined under the Schedule 32 of the NHS Standard Contract. So institutions must have named safeguarding leads. So these can be various forms of healthcare staff that need to that fill positions such as safeguarding leads for children. There must be an appointed nurse and doctor, and there is generally a designated lead for adult safeguarding and a Mental Capacity Act lead as well. So with regards to governance and oversight, there's an executive lead, as mentioned, for safeguarding children, adults at risk, and prevent. Oh, sorry, I haven't actually. So prevent, some of you may know as the, through your online training, is the government initiative to prevent radicalization online. So there'll be a lead for prevent. And through robust governance, so usually an annual report, they can identify shortfalls and work upon that. So safeguarding policy should reflect local multi-agency procedures and ensure that it's in line with legislation. Recruitment and staff management, so this would cover things such as appropriate training for individuals, so appropriate safeguarding training through either one-to-one sessions or online training. Oh, sorry, no, training and supervision. So they sort of go hand in hand, sorry. So creating a competency framework in which it's identified what your responsibilities are depending on your healthcare staff status. And lastly, I think probably most importantly is creating an organization culture that can properly promote adult safeguarding or just generically safeguarding within the institution. So ensuring that people know their local guidance, ensuring people are trained, ensuring people know that know where to raise concerns, whether it be about individuals in the community or against other or about other staff members. So if there are concerns about either of those two parties, they should foster a environment where people can openly speak up about this. So I briefly touched on the competency framework. Don't need to read that, but essentially from level 1 to level 5, level 1 being all staff that work in the healthcare system, and level 5 being those who work on the health boards for safeguarding. The Healthcare Act outlines core competencies, knowledge, skills, behavior, information sharing, and multi-agency working requirements at each level. So we touched upon it earlier, so the guidance that comes along with the Healthcare Act 2014, that outlines in a lot of detail that is beyond the scope of this webinar, what is expected for people at each level. So I think, oh, that's annoying. Sorry, I can't see. So there are actually 7 points there. And there we go. I think you can see it when I do that. So this is a handy sort of stepwise approach as supported by the BMA on how to approach safeguarding situation as clinicians. So, as discussed, identify those at risk. So those who are frail, those who have physical, sensory disability, and so on and so on. So on. Second most important step is to quantify that risk. How immediate is that danger to the individual? So does this need to be acted on promptly, and do emergency services such as the police or emergency health services need to be contacted? And can this wait, essentially? So I think the most important thing is identifying whether there's an immediate threat to life and whether that risk needs to be removed urgently. So step 3, to assess the individual's needs. So as discussed earlier, there's no blanket, there's no right or wrong answer to this. It's very much based on individual preference. But this will focus on their various sort of social, emotional, physical and psychological needs. Important to assess whether there are any previous safeguarding issues, as well as whether there are any other individuals in the house as well. So commonly making sure that there aren't any dependents, so whether that be children or whether that be, well, it could actually be anyone. Classically, children and those in care. Step 4, so capacity assessment. So along with the Healthcare Act, the second most important bit of legislation that you guys should be aware of, as well as has been alluded to in previous lectures, is the Mental Capacity Act. And so importantly, a fully capacitous adult can make decisions on their situation, and that can be a bad one. If they have full capacity, just because it's a bad decision doesn't completely rule out their capacity. At this point, you should also consider whether a best interest meeting is appropriate too. Step 5, identify appropriate referrals. So there is each local area will differ, but there's a local safeguarding adults board. There will be a adult and child safeguarding lead, as we identified earlier. And this will once again be reflected on individual needs as well. So does social care need to be involved? Is this an institutional level of abuse that may need to be reported to the CQC? The Citizens Advice Bureau, various charities specific to situations exist. So there is a wealth of support groups out there. Now, if you do ever feel lost or don't know where to go, contact your local safeguarding lead, health board, or the MDU, or whatever medical defence union you're part of, as they will be able to appropriately refer you on. So consensual shared decision making, so ensure that you're both on the same page and move ahead. And finally, review your whole decision. Take a step back and check whether there are any omissions. So importantly, mental capacity, we'll try and rush through this part. So those with capacity are able to make decisions regarding their own care and management. As long as this is in absence of any serious crime, significant risk to third parties, or whether it should be disclosed in the public interest. So the first step in capacity is the presumption of capacity. So just because it's not aligned with your objective lens of best interest, some people may refuse care, even though they may be at risk of harm. Now that's fine, just make sure you document it very clearly. It's also important to note that this is very time-specific and decision-specific as well. So it doesn't mean that you can't come back to it at a later date and reassess. Okay. Now, if you do have any concerns, the onus is upon the person who's challenging the capacity. So we'll touch upon that in a bit. And there's one last thing I want to say. Oh yes, of course. Underlying pathology doesn't necessitate that someone doesn't have capacity. Just because someone has dementia or they may have had a stroke doesn't mean that they may have capacity for that specific decision or at the specific time. So next 2 points, you should maximize their decision-making capacity. So whether that's with aides, involving other family members, ensure that you work towards maximal capacity. And yeah, it's decision and time specific. So assessing capacity. So we mentioned we need to identify the specific and time-specific decision being made. So that's step one before stage 1 and 2, actually. Sorry, that's a bit confusing. The patient should be involved and subsequently this should be communicated with them, and you should try and maximize their understanding and decision-making process where practicable. Now, if this doesn't work, you have the 2-stage functional test. So stage 1, does the patient have an impairment of the mind or brain? If yes, then that provides some sort of context to why they don't have capacity. Stage 2, that I'm sure you're all aware of, is for this time and decision-specific. So time-specific decision, are they able to understand, retain, weigh up, and communicate their decisions? So if they aren't able to maintain any one of those parameters, then they are deemed to be lacking capacity. Subsequently, decisions will be made in the best interest. Now, this very much depends on timeline. So if it's an immediate decision, yes, clinicians and those around may make the decision themselves. However, you also have to consider what's the likelihood that the person will regain capacity and how long could this decision be delayed. So for example, are they under the influence? We know that may resolve in a couple of hours, but if it's something life-threatening, then it has to be addressed at that point. Whereas if it's something that can wait, it's fine. Okay, we're doing a bit pressed for time, sorry. So as discussed in Devesh's lecture, always consider advanced directives, lasting power of attorneys for both health and wealth. If they don't have any family members, consider an IMCA. When making a best interest decision, go for the least restrictive option. What we mean by that is you want to include them all the way and try not to, I guess, completely take away the decision making from them as well. If you're concerned, you can always go for formal assessment of capacity too. So if you have the time, you can refer on to a psychiatrist or a psychologist who has experience in assessing capacity. If these informal methods these more formal methods don't work, then a court of protection can be called in. So do we have time for a case study? Sorry, I think we're actually I think I have just one more slide after this anyway. So yeah, let's do the case study. So Mr. Lewis is a 79-year-old man living alone in a privately owned flat. He has advanced vascular dementia and a history of diabetes and chronic COPD. Neighbours raised concerns to the local authority after noticing a strong odour coming from his property and piles of rubbish accumulating outside. Social worker visits. So house is extremely cluttered with rotting food, soiled clothing, and blocked exits creating significant fire and health hazards. Mr. Lewis is unkempt, wearing dirty clothes, and appears severely underweight. His medication is untouched and out of date, and he resists attempts to clean the home, becomes agitated when offered support, and insists that everything is fine. Though he struggles to explain how he manages daily living tasks. He states that he doesn't see an issue with his current living situation, but cannot remember the content of the conversation regarding support moments later. Lovely. So ignore the first question. Actually, what is the type of, ignore the first question. So does this patient have capacity to refuse any, yeah, so does this patient have capacity? I'll give you 30 seconds. Is the, feel free to comment on the YouTube live. Right. Yeah. So does he have capacity? I mean, realistically, you'd want to explore this a bit further, but the hint in here is that he's forgetting the content of the conversation moments later, so he's not able to retain any information. Thus, step one, he has vascular dementia. Step two, or part two, he's unable to retain information. Therefore, we can establish that he is lacking capacity. Thank you. Sorry, Jennifer. I think your comment just came through a bit later. Yeah, no, he doesn't have capacity. So the last section is relating to mental capacity. I know it's, yeah, so deprivation of liberty safeguards. So this is essentially when in scenarios where a patient is lacking capacity and must be held against their will to receive certain treatment as it's in the best interest. You may have seen in hospitals and care homes, a deprivation of liberty safeguard can be sought. So an individual is deprived of liberty if they are subject to continuous supervision and control, are not free to leave, and if staff exercise complete and effective control over a person's care and decisions about their care. So once you've established those 3 points, sorry, I realize I haven't actually put the third point in, but yeah, those 3 points, a deprivation, and thus established a deprivation of liberty. This must be authorized in accordance with legal process under the Dole's part of the Mental Health Act, or by a court of protection. So who can authorize a Dole's? The Court of Protection can, but in slightly more urgent scenarios, such as life-sustaining treatment, clinicians can bypass that as long as it's in accordance with the Dole scheme. Predominantly seen in hospital and care homes, and these will be referred to managing authorities within legal text. So there are 2 types of authorization that can be sought. So the standard authorization is if a managing authority needs to deprive someone of their liberty, and these applications can be, but it's non-urgent, so these applications can be made 28 days in advance. With the urgent authorization, so if it can't wait the 28 days, that's more often the case, especially if you work in hospitals. This allows deprivation of liberty up to 7 days and may be extended subsequently if the supervisory body decides that it's appropriate. Whew. So, I think the last slide. Some general tips, I think. I know I've gone through a lot of, it's been quite didactic. I know we've gone through a couple of case studies, but it's a lot of information. Summarizing it to a few key points that you should take home is that safeguarding is the responsibility of all healthcare staff. So not just clinicians, it should be anyone who is involved in the care of those in both primary and secondary care, as well as in the community. And thus highlights the importance of robust training and surveillance structures. Good communication is key. So the patient is at the center of all, the individual is at the center of all safeguarding issues, and you should work collaboratively with them, and thus communicating appropriately with them is imperative. Familiarize yourself with legislation, local guidelines, and referral pathways. So I think the MDU, MPS, also the BMA provide guidelines and various, or guides actually, for clinicians. And importantly, explore needs and act promptly. So yeah, we've covered that. So these are my references. So any questions? I'll give it a couple of minutes now. I'm just going to, let me just share the feedback. Oh, let's go back to here. Can you guys see it? Maybe not. I think I just need to stop this. So let me exit. Lovely, and you guys can see my face. So stop sharing. There we go. Stop screen sharing. Sorry about that. So yeah, thank you very much for sitting through that. I know that was a little bit longer than previous lectures webinars that I've done. I hope it's been useful. I think it's as I highlighted earlier, it's very important for all healthcare staff to be wary of safeguarding principles and how local structures work. So it's going to be slightly different in each area. There'll be various websites and documents that will differ. However, the general principle is the same. There's a safeguarding lead. There's a local authority that you can refer to. And if you're stuck, and if with the case with all of these webinars, if you're ever stuck, and you don't know what to do, contact your medical defense association. They're there to help. There's a reason why you pay a membership. So I don't think there are any questions so far. So that's the last of the webinars that I'll be giving. So thank you very much to those who've joined today, and thank you to those who've joined in the previous months. It's been very helpful, and thank you very much for all your feedback. Lovely. Well, can't see any further questions. So, actually, wait, let's see. Perfect. Anyway, seeing as there aren't any further questions, thank you very much for attending, and have a good evening.